Good morning, everyone. Welcome to day 3 of Stroudwater's 2025 Critical Access Hospital Conference. I'm Megan Hazelton, and I'll be your moderator for today's sessions. Stroudwater partners with rural hospitals across all 50 states, providing hands-on guidance in financial, operational, clinical, quality, and strategic performance. Our team is made up of former hospital executives and practitioners who understand what it takes to succeed in today's rural healthcare environment. We're here to support your team with solutions that are insightful and actionable. Our first session today will be Operationalizing Survey Readiness, a framework for daily excellence, featuring two of our Stroudwater Associates consultants, Carla Wilbur and Christy Bishop. Let's begin. And Christy, you might just need to reshare your screen.
That's what I was going to ask you. Thank you. Can you see it okay? Okay.
All right. Hello, thank you for being with us today. I'm Carla Wilbur, and we will get started on operationalizing survey readiness. Our objectives for today are to define survey readiness, talk a little about why it is important to maintain survey readiness, review the types of surveys, understand how your surveyor is preparing prior to coming on site, review state and regional 2567 survey deficiency data. We'll talk a lot about that. And then how to build your survey readiness toolbox. Survey readiness in definition is achieving and maintaining an ongoing prepared state in which an organization can confidently ensure compliance with regulatory requirements, patient safety, and quality standards. Why is this important to us? As of January 2025, as you can see on the slide, we have a large number of Medicare beneficiaries. This amount is estimated to be somewhere in the neighborhood of 80 million by 2030. So for those of us who are, we see a lot of Medicare patients, CMS wants us to maintain quality and safety for these patients. This is for the health and safety of patients, caregivers, and staff, as well as huge financial considerations for our hospital. The impact on health and safety from readiness, we do not want delayed or inconsistent care. If we have less timely assessments, a poor medication reconciliation, if we do not maintain our infection control and antibiotic stewardship, and so forth, that can impact the healthcare facility. We also want no harm. So not maintaining your readiness can impact your increased risk of harm. Non-compliance with standards that are meant to protect our patients and caregivers and staff increase the likelihood that patients may have safety events. A poor patient experience. If your patient has a poor experience at the hospital, then they may not ever use our services again. If we have gaps in communication with our patients or care coordination or responsiveness of care, that can impact your patient satisfaction scores. Regulatory citations and financial penalties are real, and survey deficiencies can lead to certain CMS sanctions. We don't want to have any impact on our regulatory requirements that may have some type of impact to our funding from Medicare and Medicaid. There are many different types of surveys. There are certification surveys, validation surveys, revisit surveys, and complaint surveys. We'll talk more in detail about each of those. Certification surveys include both your initial certification and your recertification survey. CMS says these surveys are to determine if a prospective or current participant in Medicare and Medicaid meets those applicable requirements for participation. And that's to evaluate your performance and the effectiveness of that participant's care. The validation surveys are used to really validate the performance of the accrediting organizations. Currently, there are 4 approved accrediting organizations for cause. That would be ACHC, Joint Commission, CIHQ, and DNV. Typically in our rural cause, we see mostly state instead of the accrediting organization, but there are many who do use Joint Commission and DNV as well. CMS selects providers or suppliers for validation surveys on a random basis. And last February, CMS introduced plans to strengthen the oversight of these accrediting organizations, most specifically around holding these accrediting organizations to the same standards as our state survey agencies, making sure that they were addressing no conflicts of interest, that they were addressing the regulations to the degree that CMS requires. We have seen many of our hospitals who have received a state survey then have a validation survey. If they've received their Joint Commission survey, they've then received a validation survey from CMS. So that's kind of like a 1-2 punch. A revisit survey is a survey in which that survey team reevaluates a specific deficient area that was deficient during their certification survey. So the revisit survey is just to verify that those previously cited deficiencies were corrected. A complaint survey is something we definitely do not want. A complaint survey is conducted after a complaint is filed, and the state survey agency conducts an investigation. They may or may not come on site, but if they do come for a complaint survey to our facility, they may go into different areas. They do not have to stick to just the complaint. So if they see other things that may pique their interest, they can go into that area or reevaluate. So we want another reason to maintain that survey readiness. Full surveys are the certification and validation surveys. They are always the full surveys, and they assess your compliance with all of the conditions of participation. Complaint surveys and revisit are more focused, but again, they can be expanded if the findings warrant further investigation. So how do your surveyors prepare? They prepare by looking before they come on site at the special features you have in your organization. Do you happen to have swing beds? Do you have a distinct part unit? Do you have off-site locations? They look at your prior application forms, all of your previous survey results, any of your licensures. And they've been known to recently look at any media reports, Facebook pages, and look at your organizational website. They prepare for observations, interviews, and record reviews by using that information. During a survey, a surveyor might notice that you have a damaged blood pressure machine. After they speak with your nursing staff, that may be revealed that this machine malfunctions frequently, and it had been broken many times in the past, preventing the staff from using that machine. And that one nurse tells your surveyor that the staff have submitted numerous requests for it to be fixed, but no one seems to be working on the issue. What is that surveyor going to look for? They're going to look for your records for your maintenance. During your survey, the surveyor decides to interview a patient regarding a fall. The interview may go something like, "You fell out of bed on Wednesday, is that correct?" And the patient says, "Yeah, it is." And then the surveyor may say, well, tell me more about how that really happened. So in that particular instance, the surveyor is asking these open-ended questions to gather more information from your patients. That's some of what they do during their observation. Another example, in the beginning of a surveyor reviews the facility's incident log and finds that there are several reports of med errors related to antibiotics. 2 of those errors were not caught in time and did cause harm to our patients. So at the facility, the surveyor conducts interviews with the pharmacy staff and with staff involved in that patient care. During the interviews, the surveyor learns that the pharmacy is using a new label and barcode system, but the staff claimed they were not trained on how to read those new labels before the implementation. So given this, the surveyor will probably review the med administration policies and training records. So let's talk a little bit about 2567 deficiencies. 2567 deficiencies are deficiency data, and this is available publicly for skilled nursing facilities, hospitals, and critical access hospitals. The reason that it's called a 2567 is because that's the form that the surveyors use as they complete their record of any deficiencies they find. Surveyors can use the 2567 data that shows on the site for their preparation as well. But this is also something that you can use to help prepare. There are 2 different types of deficiencies. A standard level deficiency means that this part of that condition of participation was not met. If the entire condition of participation was not met, then that's considered a condition level deficiency. The other additional level of noncompliance, which we never want to hear, is immediate jeopardy. In immediate jeopardy, the hospital faces the fact that they have to correct that underlying problem very quickly. They can be terminated from participation in Medicare and Medicaid within 23 days if that hospital fails to correct the problems. This is a survey dashboard that we've created. It is on our website, the survey readiness page, and we've pulled the information from the 2567 publicly available data so that we can kind of look at, if you want to go into a particular state, to look at the different regional deficiencies that have been found during a certain period of time. And so that's broken out into critical access hospitals, other rural hospitals, rural emergency hospitals, and non-rural hospitals, so that you can kind of see what have been, what citations have been delivered in the most recent past. CMS has, from this information, we have pulled the top 2567 rural deficiencies, and you can see those listed there. And I'll just briefly go through each of those. The first one has been the sprinkler systems. So that's something that they have found where hospitals may not have had the latest date that the sprinkler system was checked, who provided the test, the water system source, and so forth. And so that's why that particular deficiency was given. Electrical systems. It's very important that we have maintenance and testing on all of our generators and transfer switches. So typically what they find is that we do not have the records to demonstrate that we have been testing the electrical systems. Hazardous areas, they want to see that we show that we have documented any of our hazardous areas and that we have noted that and that we have those marked everywhere within our organization. Infection prevention and surveillance control, of our healthcare acquired infections. That one has definitely trickled up to the top in the last couple years because the infection prevention and control and surveillance and prevention, including maintaining a clean and sanitary environment, that can be anything. We find several, when we do survey walkthroughs, we can find different things that happen to be laying around the unit, and if it could potentially cause or transmit infection, then you can be cited for that as well. We are seeing a lot of fire drills, deficiencies on fire drills, and most of it is just record keeping. It's not that they may not have done their fire drills, they just can't show the records to support that they have. This one, we have two different tags listed here, and this is your compliance with 489.24, which happens to be the special responsibilities of our Medicare hospitals in emergency cases. So that's EMTALA. These have really trickled to the top recently. This is one of those, one of those tags that can really take them down another bunny trail. But it's one of the things that you really need to do a lot of work on, because EMTALA can come with a lot of violations and cost to the organization. Part of EMTALA is your medical screening exam. That too has come up to the top of in the top 10 as deficiencies. Medical screening exams. We want to make sure that we do a medical screening exam on all of the patients that are presenting into our ED. Unfortunately, we've been in a few hospitals recently where we've noticed that we have providers who have clicked that box about medical screening exam when they really haven't done the medical screening exam yet. And if that patient were to leave and we have said we have done a medical screening exam and then we haven't stabilized and so forth and so on, that's a huge liability for your organization as well. Fire alarms, kind of supporting that fire alarm, the drills, testing, and the maintenance of a fire alarm system has been a really important piece of deficiencies recently. We also have another dashboard that has been created for EMTALA deficiencies, and that too is broken down into the different states and your regional areas as well. A little food for thought around EMTALA and a couple of examples. The first one has to do with refusal to provide medical screening. In this situation, the patient arrived at the emergency department complaining of chest pain, and because the patient appeared to be disheveled and mentions not having insurance, the front desk staff turns the patient away and advises them to visit a free clinic across town. Why is that a violation? Hospitals must provide that medical screening exam to any individual who presents at the ED, regardless of their ability to pay. The second example is the inappropriate transfer before stabilization. In this situation, the patient presented to the ED after a car accident, and they had a suspected internal injury. After a quick exam, the ED provider had determined that the patient may need surgery, but transfers them immediately to a larger hospital before fully stabilizing them for their condition and or documenting why the benefits of transfer outweigh the risk. The reason that's an EMTALA violation is because EMTALA requires that the hospital stabilize the patient before their emergency condition before transfer. Again, unless the benefits outweigh the risk. Delaying care for registration. This is another great example. This has to do with the pregnant woman who arrived at the ED in active labor, and instead of immediately taking her back for triage or evaluation, the registration clerk insists on completing all of that financial paperwork and obtaining the insurance information before notifying the medical staff. That violation is because the EMTALA prohibits delaying medical screening, examination, or stabilizing treatment to inquire about insurance. Another thing that you can do in your hospital is walk to your registration department and ask them, what do you do? And we do not want to hear that they are asking about insurance until we have medically screened that patient. How do you use all of this 2567 data and other data that you have? This helps you. It helps you have insights into your common areas of noncompliance. Look at the 2567 data. Look at your region. Look at what has been popping up to the surface recently. It can help you prioritize the efforts that you need to do to address these potential compliance gaps that you might have. It can help you be proactive, do that proactive review and a proactive plan of correction to help you prevent or mitigate these deficiencies before your survey. It can help you tailor training and focus areas on the high-risk areas that are high risk for noncompliance, and develop your targeted plan of correction, your action plan to address those specific deficiencies and improve overall compliance at your organization. Now, Christy will tell you a little bit about building your toolbox.
Yeah, so let's talk about building your toolbox. There's six key tools of building your toolbox, and we're going to talk about each of these six individually in more detail. So they are utilizing your past survey correction plan, maintaining and documenting a checklist and assigning different owners to that, developing a revolving calendar by month to do policy review and revision of some of those and having assigned owners to those. Conduct internal tracers with a dedicated team and how to do that. Create a daily checklist that you are looking and assigning specific areas at a daily huddle, and design a pocket guide for your staff. So we're going to talk about utilizing your past survey. These are just examples of some of the findings and things that we've come across. So this particular example is that this particular hospital didn't adhere to their policy with aerosol treatment, which is a respiratory treatment. Our nurses were providing respiratory treatments to the patients, but not doing it per the protocol. So when the surveyor looked at it, they compared the two, there was a discrepancy with how the nurses was providing the aerosol treatment to their protocol. What their plan of correction was to provide education to the staff on proper admission of the aerosol treatment to the patients. What the surveyor wants to see when they come on, because they're going to have that survey in hand, ask you, what did you do with this information? They want to see the education that you're providing. How are you tracking that this education and it's being done correctly? And make sure if you're meeting 100% compliance, you're still meeting that after consecutively after 3 months. So you want to make sure you're staying on top of that and audit randomly. So the next one, the other example is this particular citation was around fire alarm system testing. So this wasn't a fire alarm tested was not being done annually, and their plan of correction was to establish a planned event to make sure that these alarm systems are being triggered and performed annually, that they have the proof and the education for them going forward. So when the surveyor comes in, again, you want to show your planned events, and you could plan these out, your annual trainings or your alarm settings out for so long, but you're also monitoring who showed up at the alarm testing annually, and all the information is provided to the surveyor when they're on site. And then this next citation was the corridor wall did not meet the minimum hour fire resistant retardant. So the plan of correction was bi-monthly inspections, and that they were doing some random audits on that resistant, again, providing that information. So if you see the key here so far is really getting that information, if you're providing education, and documenting all of that and bringing it to the surveyor, excuse me. So this next one is another fire one. As you can see, the fire is really important here, fire alarm testing and everything. In between the ground floor and the second floor, there was in the tiles, there is some work that had been done, or excuse me, I'm sorry. This is the double doors. So the double doors to the SNF was not closing properly. It was left open, and with the fire hazard, you have to have that door completely closed. So they had done some education with some staff and was able to put this on a bi-monthly maintenance schedule to have that fixed so it would close properly, to ensure that there is no additional issues with this door. So they are documenting and checking on that regularly on their maintenance schedule to make sure that this door is not going to have any further issues as far as closing. This one was I do believe, yeah, it was the ceiling tiles. I jumped ahead of schedule, sorry. The ceiling tiles, so the ceiling tiles, they were having some work done between the first and second floor between the drop ceiling. So when they're looking up in your ceiling tiles, which they do, they'll see that there was no caulking to prevent the smoke to go from one floor to another. So we are missing caulking, and they wanted to, their plan of correction was to educate their staff, if they're doing any maintenance in between those floors, that they are providing the right caulking in between there to prevent that smoke. But they're also saying that they are also going to educate the contractors. So if we are providing education to our contractors and our staff, they're gonna see that education with the contractor education as well. So when you're being asked where this documentation is, bring it forward during your survey. So the next part of our key tools is maintaining a checklist and assigning those owners. So to maintain a checklist, we're going to develop a plan. This is to look at all of your areas, to renew and develop a plan to make sure everything is up to date and ready to go when that surveyor comes in. So we're going to assign specific areas to folks to make sure they stay on top of these, such as the ED log, incident logs. Do we have our maintenance plan? How does our copy plan look? Are they all up to date and ready? Someone is in charge of having all of our meeting minutes and reports. So they're maintaining that packet, if you will. So when the surveyor comes in, all the meeting minutes are in this packet. They're all up to date, and the reports are ready to go to give to that surveyor once they're on site. Number 3 is developing a revolving calendar for policy renewal. This is a big one. A lot of the hospitals that we have been on, site surveyors, this is our policies are out of date. They're either expired, their resources are not legitimate. They don't have, so if you click on their resource, it takes you to just a generic page that doesn't refer to anything that is on your policy. So when you're creating a policy, you want to make sure you're reviewing it and it follows the policy, or excuse me, follows the workflows and what you're doing on the floor or any other process that you have, they line up correctly. Your appropriate signatures are on there. All of your resources and references are up to date and ready to go. And though having all of those are very overwhelming. You can make a schedule and have, say, nursing will start doing theirs in June, and make sure all of their policies are up to date. Same thing with like human resources, just making sure that we're following up and getting those dates corrected and renewing those policies. The next one, we're going to talk about internal tracers. This is fun. So you're gonna follow a patient. So first of all, the methodology is really looking and making sure that we are following our processes and staying up to date on our regulatory standards and identifying any areas for improvement. So for example, we are going to start with a patient in the ED, and we're going to follow them all the way up to admission and then to admission and then discharge from home. And when we're looking at that documentation, is there anything that falls out? One that stands out to me is our pain control. Oftentimes we find that our pain policy is not being followed when we're doing our documentation reviews. And so we're not doing our reassessments on time, and we're not asking patients their pain protocol. So we want to make sure that we are following that patient and looking for anything that we can utilize in there and develop an action plan from there, just to stay survey ready, to be proactive. We also want to talk about creating a daily checklist. What does that look like? We want to assign a daily checklist in the morning. So when we have our morning huddles, we're meeting with our team and we're just looking at assigning folks. These are some things that we're going to look at today to be proactive and survey ready every day. And we should be. So today we're going to look at medications and make sure that those are good. Are our egresses open and ready, available for folks to go through if it's an emergency, they're not blocked. So, and the last thing I want to talk about, the last key in our tool, or the tool in our toolbox, if you will, is having a pocket guide for staff. This pocket guide, as you guys know, I know from my experience having a surveyor in front of me asking me questions, I get nervous and I fumble and I forget what they're asking me, or I don't know the right answer. And oftentimes our staff feel the same way. So this pocket guide is just created something really simple, something really easy, just put in their pocket to pull out if a surveyor has some questions. It is okay for them to say, I'll be back, or give me a minute to find the answer. But if we're in certain areas, give them a little pocket guide to know where to look to find the answers for what they're looking for. It's just for them to have some preparedness. A wonderful quote that we really love to say is failing to prepare is preparing to fail, by Benjamin Franklin. With that being said, I would really like to open it up for any questions if anyone has anything they would like to ask us.
Are there any questions?
Hi, yes, Carla and Christy, thank you all for that presentation. You all do have some questions in here for your presentation. So the first question being is, how do you assess clinical documentation compliance and alignment with conditions of participation or accreditation standards?
Yeah, you mind, Carla, if I take over?
Go ahead, yeah.
So that's a great question. And when we do our chart audits, is really important, maybe creating a template, if you will, when you're doing your chart audits and putting in what it is you're looking for in your COPs to make sure you have a guide so you can look through that chart and document whether or not you're meeting that particular COP. Templates are wonderful and easy to use, so you're not having to search for the answer.
Great. Thank you, Christy and Carla. Another question we have here is, how often do hospitals need to do this? What is your recommendation?
For reviewing clinical documentation?
Yep.
Yeah.
And survey readiness, yeah.
Yeah, right. Well, we want to maintain survey readiness daily. But I believe that, the best practice is to do clinical documentation audits every month. If you go through the process of auditing, one a day, that takes you to where you need to be within a month. One of the things about clinical documentation audits related to your COPs and accreditation standards is, as you're doing these audits in the very beginning, you'll start to see themes. And with those themes, that's where you can do some more proactive, focused work in those areas.
Great. And how far in advance would you recommend we prepare for a survey?
Every day. I don't think there's a date that you should be ready to prepare. We should be doing survey prep work every day. When you're survey ready, that means you're preparing, or excuse me, you are giving the best and safest care for your patients. And so every day is something you want to start doing, is being prepared. You don't, and I'm guilty of this. And when I worked in the facility too, is we start preparing 2 months prior to our survey, which was never good because we're all running like crazy. So the best time to prepare is now.
Absolutely. And you could have a complaint survey, unfortunately, at any time. And if you maintain continuous survey readiness, then you will not be, faced with the possibility of that complaint survey leading to something else.
Yeah, and to that point, when they come on for a complaint survey, they can look at anything.
Mhm.
And that's why you want to make sure that you're ready to go when they're there, and at all times.
Great. I think we have time for another question here. So what is your approach to testing staff knowledge of regulations like EMTALA or swing bed COPs?
Make it fun. If we're gonna test them, we want to make it fun. Oftentimes in morning huddles, we're talking about what's going on, and some of it's never fun. But we want to make sure that we are making it fun. So ask them some questions about the COPs and have some candy available if you're looking for something in particular.
Yeah, that's always a great thing. And if during your morning huddles, it's a great time to just have some little pop quizzes. What are the three main things that our organization needs to do to maintain compliance with EMTALA? Medical screening, stabilization, and then transfer if needed. See what our staff members know. The best practice is we need to teach at orientation and annually, and then we can do these little pop tests during our morning huddles.
Great. And can you guys speak to some of the triggers that may alert CMS to visit the rural hospital?
The trigger would be if on a complaint. They're triggered. They are also triggered to visit once they've had an accrediting organization to come in for a survey. CMS now does, and they can. And they don't always do it, but they can, and we see more of it. They can follow up with another survey. The other thing would be, you have your regular surveys that you're required to have. So we fell behind a bit. The state fell behind a bit during the pandemic, but they're catching up. And so that you will have a survey in a regular period of time, at least every 3 years. And for the accrediting organizations such as DMV, they visit every year. So they're always there. So, but if there are triggers that, as far as complaints, then CMS can come in anytime, or the state.
Great. Well, thank you, Carla and Christy, for today's presentation. We do have a few more questions in the chat that we did not get to answer today, but we will be following up with all of the session attendees with the answers to those questions. We will be ending this session so that the next one can begin. If you are joining our next session, please just return to your calendar invite and click the link to join the next session. It may just take a few minutes for the next session webinar to begin, but we thank you all for joining today's first session, and we hope to see you at the next one.
Thanks,
Thank
everyone.
you.